Can everybody hear me?
I can hear you.
Okay, I'm going to start. Okay, so I'm going to go through how we, just some basics in spinal instrumentation. I've cut this course talk down to make it less technical, hopefully. So I'll just get started on. So obviously the spine can be very confusing in terms of instrumentation, and here we use different constructs, applications to them are. So I've sort of divided them up here into the pedicle screw-based, which are from posterior, your anterior plates, rods, and screws, which obviously from the anterior aspect. Some devices called interbody devices, and interspinous devices, and sublaminar devices. And I'll sort of try and give an example of each of those. And those are the basic five categories which I know of for spinal instrumentation. The common one you guys have heard of is pedicle screws. So they are posterior-based instrumentation. They're extremely strong. It's the strongest fixation point in the spine. And pedicle screws in from anywhere. I mean, you'll mostly see them done in the lumbar spine for degen and for the thoracic spine for trauma. But you also use pedicle screws in the cervical spine. Obviously, the pedicles in cervical spine are much smaller, and you've got the virtual artery to deal with, so they're not as commonly done, but we do use them. Very rigid, and probably the most powerful system for fixing the spine is your pedicle screws. So this is a typical pedicle screw construct. Shank is new ones with a differential thread, because this part of the pedicle sits in, part of the screw sits in the pedicle. This part goes in the virtual body, which is softer. Usually polyaxial, so it allows you to do planes, and you connect the rod and sometimes a connector. You can see over here, this is where the pedicle screw actually goes. It goes through the pedicle, at the base of the facet joint, and where the transverse process meets body. And this part here has a very hard tube, and you get extremely good purchase into the constructs. We've got a whole bunch of plates. You may have rod systems and different combination of those. You can do them from the front only. So in the cervical spine, you may see me putting a plate on without anything from posterior that's strong enough. Sometimes you may need to augment it with the posterior screws, so-called front and back procedure. And sometimes you put in structural bone graft. And I'll give you some examples of it just now. But there are a whole bunch of anterior constructs. Called anterior plate. This is cervical spine plate. We've got a polyaxial screw. It locks into the plate. Not so much that we want a lock plate construct, but also we don't want the screws backing out, because obviously in the cervical spine you've got the esophagus, and the backside you're going to get erosion of the esophagus, which is embarrassing. There's lots of different designs. They've got holes in them, so you can see through the plate to see if there's bone graft or bone fusion between the virtual bodies. So there are a whole bunch of interbody devices, ranging from fusion devices to motion preserving devices. So the rationale is if you're doing a discectomy for whatever reason, you have a gap here, you want to fill the gap with something. So you can either fill it with bone. What bone you put in? You put in crest, that's a structural graft. That's fine. Obviously, besides the donor side mobility, you've got a autograft here, that can collapse, fragment down, so it often you lose height. So where we put in fusion devices we call cages, which holds the space open, and we fill them with bone graft until the bone goes through the cage. Disc replacement in this place here, and a whole bunch of different implants we talked about. We've got some fusion devices. These are peak. You see there's a nice space here for the bone graft to go inside them. And this cage here holds the vertebrae apart until the bone graft incorporates. This is peak. Properties just now, it's titanium. A whole bunch of disc replacements and thousands of designs. You really want the end plate to integrate with the virtual body. These are coated. There's some with titanium spray. Basically, with the end plate to grip onto the bone, then you've got a either articulating disc here or sometimes placements of polyethylene thing. You might have heard of interspinous devices. I'll chat about this. What they are is they go in between the spinous process at the back here. So as we age, the discs lose height, and in this case it bulge. Obviously, if it loses height, it's getting softer. It's bulging out to the front or the back. In the back, it might. Now, as it loses height, your ligament flavum tends to bunch up and may bulge into the canal. And diagram, unfortunately. The interspinous device is designed to go in between the space to jack us up and to unbuckle this flavum, which is buckling in. Look like that. That's called local kyphosis, but downside. A couple of them. Couple of them. They're easy to put in. Get a percutaneously from the side. Easy to put in, and it does cause local kyphosis and unbuckles the flavum from there. It's okay, but they don't last terribly long. The spinous process is not really designed as a weight bearing device. And then you lose height again. So, sublaminar devices. So these are devices which you go under the laminar, and you can put wires or hooks. In the old days, these are wires you go under the laminar. Don't forget your spinal cord is running between the back of the body there and the base of the process. So these wires do encroach. You can see the cord. Wires do encroach. It depends how you put them in. You can dent the cord and paralysis. It was embarrassing. But they were what was available, and you wire them onto these solid stainless steel rods at the back, sometimes hoops, and fixation points. These are everybody hear me? Mute. Stop the video, maybe just a signal for them. Sound any better? phone. Can everybody hear me on this? Just turn off. Okay, is it better?
Yes, we can hear you.
Okay, great. Sorry, I've got this problem with my laptops, brand new laptop. Okay, so let's just try that again. Okay, just give me a shout if you don't hear. This is a typical sublaminar hook. So the hook goes under the lamina, and once again, it's a good bailout option if your pedicles are very small, if you don't get a grip. But once again, it does take up space between the spinal cord and the lamina, so there are some concerns with that. And we very rarely use sublaminar hooks nowadays or wires, but they are an option if you do have a problem with a tiny pedicle or the pedicle's fractured. Okay, so why do you put instruments in? So the obvious one is to fix fractures, all right? So same as you've got in general trauma, you want to fix a fracture that provides immediate stability, and you can get the patient out of hospital quicker. We use it in fusions. So a fusion in spinal surgery is to get one bone or vertebra to grow onto the other one, and we mostly do it for pain relief, because most of our fusion surgery comes with degeneration. You may also choose to try and treat deformity, so if sagittal or coronal imbalance, and you also use it for neurological decompression, and I'll show you some examples of that. So fractures in the spine. So stability, we describe stability as the ability of the vertebral column to maintain anatomical alignment or relationships under physiological load. So if you have a stable fracture, let's say a compression fracture, like a simple wedge fracture of a spine, you can get up and walk around, it's not going to displace. But if you have, there's a burst fracture or an unstable fracture dissection, that will obviously displace under physiological load. So a lot of fractures are initially unstable, and they will stabilize with time. The problem is the time is the denominator. So the femur fracture will also stabilize with time, but it's not feasible to keep a patient in hospital that long, and we tend to fix him to mobilize earlier and to maybe have a better anatomical shape when you finish when it's united. And some fractures will never heal or never get stable. So for instance, the ligamentous chance fractures will never stabilize. The cervical facet dislocations never stabilize. Those are discal ligamentous injuries, and they will never stabilize with time. So we have to fuse those. Neural compression is another reason to instrument. So we may decompress a foramen, for instance, and deformity. So I'll show you some of those examples. So when is a fracture unstable? So in general, if you have a two-column injury, that fracture is unstable. So I will get confused between three columns and the anterior column and the big. Very simple. If your anterior column is disrupted and your posterior ligamentous complex is disrupted, it's an unstable fracture. Okay, that needs to be stabilized. Where you don't expect bony healing, so in a discal ligamentous injury, so a soft tissue or ligamentous chance or a cervical dislocation, we don't expect bone to heal then. And we want to get the patient mobilized. So obviously not everyone can lie in bed for a prolonged period of time. The instrumentation allows us to get them up. Okay, so in general, your Rod screw construct or plates give different plane stability. In the cervical spine, we have a choice to go from the front to the back. And a lot of that choice depends on what we're trying to achieve. So if you want to try and decompress a cord, and if the compression is anterior, we go from anterior. If the cord is posterior compression, like flavum, you may want to go from posterior. So that decides us. The thoracic and lumbar spine are defaulted from behind. The pedicle screw is available, very strong fixation, and most of our thoracic lumbar surgery is from posterior. Okay, so fusion, we want to treat pain. So degeneration is a common one we use, so spinal degeneration, infection, and tumors. We may want to do a fusion for deformity, so your sagittal imbalance, a typical Scheuermann's disease with kyphosis, or lumbar spine of the flat back. We want to use instrumentation to restore the alignment, and it's a typical scenario we would use instrumentation. Coronal imbalance is a typical scoliosis, and we obviously have to instrument those. Show some pictures of these. Okay, so neurological decompression. Laminoplasty is the technique where you enlarge the cervical space by putting plates in the lamina and fracturing them and making the space bigger. In the lumbar spine, we may want to choose foraminal decompression, and then we need to instrument to increase the size of the foramens. Okay, we're going to go through some cervical instrumentation first. Make it too complicated now. Okay, so the peg screw. We've all seen peg fractures. The typical peg fracture we want to fix is type 2 peg. That's the one that tends to not unite. There's a high instance of non-union, and that's the one we need to fix. So here's a cervical peg. You can see the fractures through the waist there. This is patients for your earrings in. But the typical type 2 fracture, it's a high instance of non-union, about 60% plus, and we need to stabilize that. The type 1, remember the type 1 is an avulsion of the tip. We can treat those in a collar. And type 3 through the base of the peg, we don't need to fix it because they'll unite quite nicely to a big surface area. You can treat those if it's displaced in Cohen's calipers for 6 weeks, and then we'll unite. But the type 2 tends to not unite. There we go, there's a fracture on the CT. You can see the type 2. And fixation of this is by putting a screw with a lag through the peg. It's quite a fiddle to approach the patient. You've got to get the trajectory. So you want to make sure that you can get the angle of the peg like that. We need biplanar fluoroscopy. So you can imagine trying to put two C-arms in theatre at 90 degrees to each other to see your angles. Obviously, the fracture principle still applies. So the fracture is, ideally you want the fracture between 90 degrees to the screw. If the fracture is in this plane, you can't fix it. It'll slide. So that's not amenable to fixation. And this is a typical scenario seeing is a retractor you put under the neck, you make an incision around about 5-6 level, and you just go under the esophagus, put your retractor up here, and that's your line of sight. The patients with a short neck and a big barrel chest, you often cannot get the angle to get the peg screw in there. It's technically quite challenging. This is described to use 2 screws. One screw is mechanically good enough. That's the angle of your screw. So this is a typical, this is a well-fixed peg. It doesn't look like it, but it is. So you can see a couple of problems. So first of all, the screw, you tend to violate this C2-3 disc space to get the access. And sometimes the screw breaks out here, so you get early breakout. The screw looks like it's gone to the back of the peg. Maybe your cord is running between there and there. That's where you don't want to go. This patient's nice because there's no teeth, but I promise you, there's teeth. They're always lying over the foyer, and you cannot see the peg very easily. So it's a difficult approach, technically quite challenging. But it is described to fix a peg, and I've done probably about, I guess, 10 or 15, and it's not a very satisfactory operation. But you just need to know about it. So this is a bit about C3 to C7 instrumentation. Need to miss out some of this. Below the we call the subaxial spine, so C3 to C7. We tend to go anterior. It's a nice easy approach. It's called the Smith-Robinson approach, and allows us to do various different things. So I'll just skip through this. So ACDF, so anterior cervical decompression fusion. Here's a patient with a dissection, looks like unifacet. You need to instrument this, okay? Because this patient, even if you get it reduced, it's still got no bony healing potential. It's gone to the disc and it's gone to the facet joint, so it's nothing to heal on here. So there's a very high incidence of redissection. So you want to instrument this. Without instrumentation, you have to mobilize in orthosis, like this unhappy fellow, or even a halo, but it's still not very rigid fixation. So the instrumentation allows you to directly get purchase in the bones. It's rigid fixation, fusion rates are much higher, and prevents all these complications. So this is a standard anterior approach, and you've got an anterior cervical plate. We call it ACDF, anterior cervical decompression fusion. There's a plate. We've got a bit of eyelet crest autograph in here, and this is a basic workhorse of cervical trauma. There's a couple of advantages for anterior approach. I'll discuss them just now, but this is what we tend to do most of all for trauma, and works very well. So why do you want to go from anterior? So you can get to the anterior column, support and reconstruction. You may have anterior cord pathology, so don't forget, if you've got a disc in the front here, maybe dent in the cord from the front, you can only come from the front. You cannot decompress the cervical spine from behind if you've got a disc in the anterior part. And last, deformity correction. So what's the approach? It's called the Smith-Robinson approach. You must know about that. Don't know what the rest of the stuff is, just not important. That's your typical ACDF. You can go to multiple levels from the same approach. So we often, patient might come with multi-level disease, and you can do multiple levels to the same incision. It's a nice scar. It cosmetically heals very well, and there's very little muscles in the front to disrupt. The anterior approaches also allow you to do much more. If you have a tumor, for instance, you can do a corpectomy. So this patient's had entire vertebral body removed. That's 2, 3, 4, 5. So C6 has been removed, and this will be a piece of iliac crest, or you can use fibula. It's a nice big strut. And obviously, it's not particularly stable, so you need to span it with a plate, which almost acts like an internal X-fix. You can put expandable cages in here, and that's what we do for tumor probably, but they're very expensive, and this is a nice cheap option. And iliac crest fits very nicely into the cervical spine. It's a nice fit. It's biological. It's got a similar modulus to the bone you're taking out, and my preference. There's a whole bunch of different plate constructs in the market. This is a standard synthes plate, from pointy tip self-drilling screws to blunt ones, and these are often fixed angles. You can see the screw head, it's got a split in it, so often there's a small grub screw you put into that, which expands the head and prevents it backing out. Because you can appreciate here, this is the esophagus line here, and if the screw comes out, every time you swallow a piece of steak, it's going to erode. And if you get erosion here, you get the most horrific gram-negative infection around the screw heads. There's different types of plates that I found. Some got polyaxial screws, some allow for screws to move, so you get a sort of dynamic loading plate. But there's no real advantage to plates, and I wouldn't use them. So plates, obviously complications. You can erode the esophagus, the plates could move and compress the airway. Other thing is, you can see this plate here. If your plate is high riding, and it'll definitely cause acceleration to damage to the disc above. Whether it's because you've got a very stiff modulus of elasticity here and suddenly changes, or by putting a plate in your damaged disc, not always sure, but often with the high riding plate, you'll see that superadjacent degeneration, and that's a problem. You know, some of these patients are quadriplegics and their head is their functional limb, and you go now, you're obviously taking some motion away by fixing them. You don't want them to start getting, accelerated degeneration at adjacent level. So if you're quite careful and put the plates and not to encroach on the disc above or below. So interbody fusion cages, these have been around for decades. They're made of different materials. So really they are, instead of putting bone graft in the neck, these are, because there's some problems with bone graft, these are hollow implants that maintain physiological height. You allow the bone to grow through, they give you stability. So one of the concerns, so if I go back here, you can see this one. So he's had some bone graft putting here. So this is trauma. In trauma, you want a plate to hold, remember you've torn through these facet joints and just, in a trauma situation, you always want to put a plate. But if you've got degeneration, like a patient with a degenerative neck and disc prolapse, you don't have to put a plate on. Okay? You can just you can take the disc out and decompress the canal or the nerve and just put a small little bone graft in here. But these bone grafts tend to collapse. So it depends how you harvest them. So if you harvest them with saw, oscillating saw, then you get thermal necrosis and mainly do not. Also, osteotome, you get microfractures. So you often get subsidence and loss of height of your nice operation like this. Obviously, putting a plate on does prevent that. So I like a plate, prevents collapse. But a plate also means more stripping and more likely to get adjacent degeneration and so on. So there are complications of plate. So that's why a cage is designed. So you can pop a cage in there, which maintains your height. It's got much less. You don't have to take a massive piece of graft out of the patient's crest like this. So there's all the advantages. And also you don't use a plate, which is quite nice. So there are advantages to using a cage. And that's what I'm describing now. So the cage allows bone growth, it stimulates fusion, it gives immediate stability. Remember, in the degen situation, all your ligaments are intact. It's not like trauma when you have disruption. You've got intact ligaments, about just stretching those ligaments, it gives a nice press fit. And really the cage is designed to prevent disc-based collapse from autograft collapsing now. There's obviously less donor site mobility because you're not taking a big structural piece of crest graft. And it's quicker, it's time. So titanium is the most commonly used. It's very biocompatible. I won't go through all the tribology, but it's been around for a long time. You sort of supposed to get osseointegration of the titanium and integrates. But there's other systems. So this is PEEK, stands for polyethyl ether ketone. It's a type of plastic and it's very similar modulus to bone. It's much more radio lucent, so you can see nicely what's happening with this bone through it. It's with minimal effect. See, this one comes pre-prepared with some probably calcium hydroxyapatite in it. I don't like this. I always prefer your own bone. There's nothing better than your own bone. There's different designs. There's some little metal spikes in them. Some have got HA coated. They spray to the HA coating or even a titanium coating spray. Because remember, plastic, the bone won't go on a plastic, but it will go onto titanium spray or HA coating. So there's so many different types of cages and all do essentially the same thing. Okay, so this is new ones. They're coating PEEK implants of titanium or HA, and also make porous PEEK networks of bone growth. So there's a typical cage. This looks like it's titanium, so it maintains your height. You don't usually get graft subsidence, and so on. But there are obviously some problems. So if you've got osteoporotic bone, a very hard titanium will break into the bone and get settling. You do get some rocking of the end plate here, so you must brace these patients. Otherwise, you can get a non-union and they can displace and so on. But this is really a press fit. This patient's lying on their back when you knock us in, and when they sit up with the weight of the head, the sinks is very, very tight here. I've never yet seen one dislocate post-op. And after 6 weeks, it's fairly stable. The patient can start doing more impact activities. So it's a great way of doing a simple anterior cervical decompression fusion, and it's a quick procedure. Then putting a plate on, which is more stripping and technically more challenging, putting screws and making sure it's very nicely. Okay, so there's a bunch of motion preserving devices in the neck, so disc replacements. And this is because of a problem with fusion. Okay, fusion, you may get fluorophorosis, so the bone may not unite through here, and you get a loose implant, and then causes pain, and with time it may subside. And also by fusing the neck, now this segment you can imagine is very stiff. This one has to work harder, so you accelerated degeneration here, above and below. So this stiff segment, especially with a rigid plate on, it's very stiff, will cause accelerated degeneration above and below. Not terribly much, but it is there. So disc replacement on effort to try and prevent that. Okay, and this will be just trying to show some disc replacement. So this is a patient who's got some degeneration between 5 and 6. You can see loss of disc height or osteophyte at the back there. This is an MRI, so a piece of disc osteophyte digging in a cord. And these had a fusion. This is a peak implant. These are little markings to show the where the cage is in terms of your placement on x-rays. And you look at the pre-op height, so it's quite narrow. It's about 3 mils. And you can see, imagine the foramen is coming out here. The foramen is closed down because it's lost height. And by putting in the cage, you've jacked them up, you've indirectly decompressed the foramen, and you're also getting a solid fusion because there's autograft here. That's typical standalone anterior cage in the cervical spine. And this one's made of PEEK. But now, long term, this is now stiffer. That's already quite narrow. You have to work harder, above and below. I'm worried about that. There's another patient with a nice big fat juicy disc in a cord. This is bread and butter stuff. So probably a younger patient, he has less degeneration. And you know, my default is to do a disc replacement. This is a total disc. It's 2 flat surfaces, and it's got a, like a metal bearing. And this is a motion preserving device. Patients just seem to do better with it. You explore the whole space, there's almost never substance, and they do very well. This is a disc replacement. There's another type of disc replacement. This has got a poly bearing inside, and these 2 little titanium cups sit in the bone. You've got a special arena which cuts a little saucer there, so it's nicely, and you go right up against the back of the body. The cord space is from there to there, so there's lots of room. Huh? Okay. For some reason, these slides are always mixed up. Posterior cervical instrumentation, we've got a whole bunch of types you can know about. So we sometimes want to confuse C1 and C2. So for your Jefferson fractures, your peg fractures, and also the Hangman's fractures, you may want to do fusion there. And we have options from posterior. So the Gallie Fusion is a C1-2 fusion. It's a posterior wiring technique. And essentially, you're putting sublaminar wires under the C1 arch and the C2 spinous process. And you're going to put some iliac crest graft called an H-shaped graft, and your wires in place. That's so-called Gallie Fusion. But it's basically a sublaminar wiring technique to cause a C1 to C2 fusion. It's a very old technique, and you must know about it. I think it was asked in the last exam, the Gallie Fusion. The disadvantage of Gallie is that obviously you're getting sublaminar, so these wires are going between the lamina and the cord. So if you're clumsy, you could dent, you could bump the cord. You also need the C1 arch to intact, so your C1, you'll get fracture and waste of time with the arch. And it doesn't give such rigid control. Yeah, so it's sublaminar, it doesn't control rotation very well, and forces. If you've got arch fractures of spinal bifida, you can't do it. It also is not that useful for reducing the Odontoid peg. You sort of need to align the peg and fix it inside you. You have to mobilize the patients afterwards, and there's a high pseudothoracic rate. So the Gallie Fusion or the sublaminar wire technique is a very old historical technique. You must know about it, but you tend to not use it nowadays. I've never done it, and I probably wouldn't know how to do it. So the other way is to fix a C1, C2 joint. You can put a screw across it. So this is your typical C1 to screw. You go from posterior, and you literally start a millimeter lateral to the cord. You go across the C1 to joint. The reason why we go so close to the cord is you don't want to go laterally and hit this bad boy here, the visual artery. If you hit that, often you'll see the blood coming out the back of the jaw, hitting the roof, and there's a lot of shouting in theatre. It's not a very pleasant vessel to hit. So this is a technique. You basically go straight ahead. It's a straight screw across the C1-2 joint on both sides. And I've done lots of these. you get medial to the artery. From the lateral view, you can see it looks like that. You normally in X-ray see this big foramen transversarium, but you actually get medial to it, so it doesn't matter. Now, to do the C1, C2 screw, you have to have a really reduced or aligned the C1, C2 joint. You can't use a screw to align the joint. So you've got to be able to reduce the fracture with position in the theatre, and once you've got it positioned, you then put your screw through it. Your screw does not align the C1, C2 joint. And you can, in addition to that, you can do sublaminar wire to make it stronger, and your H-shaped graft to C1, C2 if you want to. That is a described technique. Okay, so that's a fixation. There's obviously superior wiring. You don't need a C1 arch, and you can add it to the Gallie Fusion. You can maintain reduction, but you can't cause reduction with it. That's an X-ray of the C1 to fusion. It's again transarticular, and so on. Okay, I can write the disadvantages. Okay, C2 pedicle. You can actually put pedicle screws in C2. It's a nice big fat pedicle. So what I'll do in theatre is I'll just do an amniotomy. So I want to see the arch of C1 arch. I want to see the cord, and you can actually probe this pedicle quite nice. You can often put a Watson chain or a McDonald here. You can see the C2 pedicle directly, and you want to aim your jaw alongside it. You have to converge. It's usually about 45 degrees. If you don't converge, you're going to hit this artery out here, the ventral, and you don't want to hit that ventral artery. This will be the technique. So you want to expose this medial side of the C1 to see the pedicle, and you put your screw through it. The screws are converging now at 45 degrees as opposed to the transarticular screw, which goes straight ahead. You must know about the Harms fusion. That's a C1, C2 fixation called the Harms fusion. So it's basically a C1 lateral mass screw and C2 pedicle screw. And that's indicated for most of our C1 to instabilities, your rheumatoids, unstable Jefferson fractures, and so on. So the C1 is got lateral mass, the base of the arch here. It's quite a tricky dissection. You've got the base, you go along the arch here, get down and find the lateral mass. There's a very rich venous plexus here. It bleeds like hell. You can often lose 300-400 mils of blood without realizing it. But basically, your starting point is the middle of the lateral mass of C1, and you're aiming anterior straight ahead for the front of the arch. And you combine the C2 pedicle. Now you've got independent control of C1 ring and C2. And it's a very powerful fixation. And then you can manipulate C1 and C2 and align the peg or whatever you want to do with it. You connect the two screws by rod. And you've got that's called your Harms technique. C1 lateral mass screw, lateral mass to C1, and C2 pedicle screw. And it's a very powerful technique. I've occasionally, I did one about 2 weeks ago. We had a patient with an unstable Jefferson fracture with this lateral mass displaced about here. And I use a cross link between these two so they can pull the screw head immediately and reduce the lateral mass. You can see there's a bit of clockwork around here. It's nice little virtual again. You have the cord, you have the epidural. So it's quite a fiddly technique, but it's very worthwhile. It's basically a very useful technique for treating axial spine injuries. Okay, this is a Harms fusion. So once again, C1 lateral mass screw and the C2 pedicle screw. And these pedicle screws should be a bit more convergent. If you're going to go straight, you need the visual artery out there, but that's your Harms fusion. And then you tend to want to lay your bone graft, your decortic at the back, the arch of C1 and the laminar C2, and you want to put strips of patient's eyelid crest in there. You don't want bone dust because it just disappears in the soft tissue. You want to put strips of crest in. So the C2 pedicle screws are coming in at 45 degrees, okay? Sometimes you can't get a pedicle screw. Sometimes the visual artery might be sitting over here, maybe different anatomy, maybe the pedicle is broken. You can't put a pedicle screw. In that case, you can do a laminar screw. C1's got a nice thick laminar, it's about 5 to 6 mil thick. You simply put a screw over here, directly across the laminar, and the one other direction. You stagger the one low, the one high, they pass each other in the bone. And that's a really good technique for getting fixation of C2 with your laminar screw. It's very safe. It's almost idiot-proof. It does look horrible in the X-ray because your screw heads are all over the place, but it's a very good bailout option if you can't get a pedicle screw. Or let's say, for instance, I'm putting a pedicle screw here, and I violate the artery, get an arterial bleed from vertebral. I may choose to leave a screw to control the bleeding. I don't want to come aside because if I damage both vertebrals, the patient will end up with a stroke. Then I cannot do the pedicle screw inside. Then I'll probably do a sublaminar screw. So it's a good bailout technique to have. You can fix the occiput to the cervical spine. Look, the old techniques used to use wiring and halo vest and the whole story. A real mission nowadays, you've got plates that fit in the back of the head. So, for instance, patients with occipital cervical instability, rheumatoid arthritis, trauma, and anything which destroys the North C1 joint, you may want to fuse the occiput to the cervical spine. Rheumatoids often get this cranial or basal imagination where the peg starts to disappear into the head, and you may want to reduce it. So there's your occipital plate. You want to go below that nuchal line because above here is your central sinus. There's a nice thick bone there, probably about 16 mils thick. And you put your screws in there. So it's a really strong occipital. It's also a lot of thick muscles attaching here. So you can't feel the plate. And it gives you really strong fixation to the skull. And you can just connect that onto your rods, onto your cervical spine. So you may want to have a C2 pedicle screw, and you can connect. So basically, it's connecting your skull to your cervical spine. That's occipito-cervical fixation. There's a lot of rods which are hybrid, so you can attach these polyaxial screws to it, and maybe some plates there. So they allow you lots of different options to fix a skull. This is another schematic of the occiput fixation to the C1 lateral mass screw and the C2 pedicle screw. That'd be a nice operation for rheumatoid. They've got a cross-link as well, which gives you more rigidity because each system is now connected. You can appreciate that you'll be quite careful when fixing the skull to the cervical spine that you don't end up with the patient's head an extension or flexion because they're now fixed, and you take it for granted your C0, C1 flexion extension. If your head's fixed, you may not be able to, look ahead or achieve a comfortable position. So it's very important to make sure you have got the eye gaze orthogonal to basically what you're fixing onto. These are lateral mass screws. I'll show you some pictures of them now. So anything below C2. So from C3 to C7 using lateral mass screws. So the vertebra's got a so-called lateral mass, which is really where the facet joint is made of. And you can go straight here, but you've got a shorter screw trajectory, and you want to stop short of the vertebral. If you go laterally, you miss the vertebral, and you get longer screw length. So you can usually get about a 16 to an 18 millimeter screw in these lateral masses. And it's quite nice for multiple levels or even segmental fixation. They're stronger than a wire, and you can use it after laminectomy. With a laminectomy, you're taking the lamina out here, you still get the lateral mass intact, so you can still fix it even if you've done a laminectomy. So there's different techniques. This is where the screw goes. Obviously, if you're going to make a screw, if you're not diverging enough, you may go too straight and enter the vertebral arch here. Or if a screw goes too far anteriorly, the cervical nerve root runs out here, you can hit the nerve root. So there's a couple of complications there, but it's a very easy technique, and you actually can do it without screening. I very, very screen while I'm doing it. So the disadvantage is your vertebral arch injury and segmental nerve injury. So this is where your lateral mass screw sits. You want to be parallel with the joint of the facet joint, and it's a really nice little screw to put in. Using polyaxial screws, and you obviously have multiple screws you can connect to the rod. And there's a patient who's got looks like multiple level cord compression. It looks like he's probably a post-traumatic patient. So I'm seeing a tear in the front here, maybe of the LL. And it's a typical case. You'll just take all this phlegm out and do a laminectomy. There's a patient sitting. So this is a Mayfield clamp. You're holding a head with a pins in the skull. This allows you to extend the neck or flex it, and basically control the head in space. It's quite useful if you want to try and now line up let's say an unstable peg fracture. You can manipulate the head to line the peg up, and you can fix it. This is a typical set that comes on it. These are lateral mass screws in the fluoroscopy, so parallel with the facet joints. And there you can see the screws in. So this is a midline, the spinous process has been nibbled away. The lateral mass screw comes laterally. I'm going laterally to avoid the vertebral artery in front. And all you do is connect to the rod, and there's your laminectomy. I've taken the lamina off here, so there's a spinal cord exposed. Okay, when do you want to choose to go from the front or the back, or the front and back? So there's lots of decisions. Mostly, where's your pathology? So if your pathology is anterior, you want to go anterior. Sometimes depends on your difficulty of access. So this can be, around about T4. It's quite hard to get there because the sternum's in the way. And you may want to go from behind if that's an option. And sometimes depends on your comfort levels. How good are you at what you're trying to do? It can be quite nerve-wracking sometimes to dive down into the neck. Like this. Okay, so talk about the anterior approach is important. So anterior approaches are useful. So the patient's supine, you have to prone them. So if you've got a patient with unstable spine, if you have to prone them, obviously there's risk of neurological injury. So with the anterior approaches, you don't have to prone them, so you prevent it. You get great exposure from C2 to T1. You can see the disc and the cord. You've got big surface interbody fusions. So the anterior approach has got a high fusion rate, and the muscles in front are very thin. You've got some strap muscles there, platysma, and you're not devitalizing this really large posterior neck muscles, which the posterior approach does. There are some disadvantages to the front. So the anterior approach, the so-called Smith-Robinson approach, you may have aerodigestive tract injuries. I did an anterior approach once, and I think I was probably in the early part of my career, and I was happily going on a peanut, and I managed to peanut my way through the esophagus until I saw the nasogastric tube. That was a bit of a shock. So besides the aerodigestive tract, you've got your neurological structures, the recurrent laryngeal and superlaryngeal, and the sympathetic trunk. You get some vascular polyps with not so much the carotid, but if you get lost laterally, you might encounter the jugular vein. It's nice and thin-walled. It's perfectly made for a peanut to disrupt. And on the left side, you have the thoracic duct. The posterior approaches are fairly safe. There's not much to damage except meat. Problem, you have to prone the patient. You do damage the muscles quite a lot. You can damage a visual artery. And obviously with anterior pathology, you can't get to it. This is a Smith-Robinson schematic. So this patient lying in the back. So there's a better picture there. So you're basically going between the carotid sheath and your esophagus. So you've got basically a horizontal incision in a cut platysma. You'll see the sternocleidomastoid. That goes laterally, and you want to get down early and find your carotid. It's a nice robust structure. Once you're on carotid, then you're just going to go in this plane between carotid and your esophagus and trachea. So here your esophagus and trachea has been retracted to the side, and it's a beautiful approach to see your cervical spine. Eh? You want to go under the longus colli, because on these longus colli runs your sympathetic trunk, and if you damage those, you're going to get a Horner syndrome. Posterior approach, basically midline approach, cut down. You want to try and find your ligamented nuclei. It's not always a straight line. It weaves a bit if the patient's extended, and you want to try and stay in it, because if you miss it, you're going to go into the muscle, get bleeding. But basically, you're going to get down onto your spinous processes, and you want to go subperiosteal, just dissect subperiosteal down and reflect this muscle out the way to get to your bones. Okay, so I'm going to talk a bit about your thoracolumbar instrumentation from anterior. So we've got a bunch of tools you can play with, from cages to plates, rod screw constructs. So why do you want to go transthoracic? So most neural compression is from the front. So most the disc is in the front, obviously. Trauma, your burst fractures, all the bony compressions from the front. Tumors will tend to start off in the body, and we know TB starts off at the front as well. So most of your compressions from the front, and that's where you want to get to, is you decompress the cord. So this is a patient who looks like TB, nice thin walls, abscess, homogeneous contents. It's eroded the bone, typical picture of TB. There we go again. So you see the thin walls, abscess, homogeneous contents, and it's scalloping and eroding the body, preserving it. This beautiful picture of TB, multiple level involvement, kyphosis. That's a slam dunk tuberculosis right there. So if you want to go deal with this directly, you want to go from the front. There's a patient with there. This is an osteosarcoma, single body involvement, leaving the disc intact, eroded into the canal. Angiopathology. This is a patient with thoracic disc osteophyte complex, gone into the cord. Obviously very old MRI scan, there's some cord signal there. So what's the strategies? Basically from high thoracic down to T6, you want to go on the right hand side. So your high thoracic, the reason for that. So T3 to T6, you want to go on the right hand side of the chest wall. Anything below T6, you want to go on the left. Okay. You can come on the left T6 and above, but your aortic arch is very prominent up here. It's going to be in your face. It's quite problematic, you know. It's really a prominent thing that's bumping around, and you can't really mobilize that easily. So above T6, you want to go on the right hand side. Below T6, left hand side for everything. Okay. You can extend it through the diaphragm and go thoracoabdominal. Left hand side is still easier because you don't have the liver in the way. And the aorta is a nice robust pipe you can find. You can cob it out the way. You don't want to be playing with the nasty vena cava and the zygus and hemiazygos on the right hand side. Those very fibril veins. You can go there, but it's not as easy. So the strategy is above T6, you want to go on the right side thoracotomy. Below T6, the whole way down, left side is easier. So these are some constructs you've got. So this is a rod screw construct from the front. It's cheap. It's actually a pedicle screw, which we just put in the front, directly into the body. This patient's had probably a corpectomy, and this looks like a piece of humerus I've stuck in here. There you can see the humerus. It's basically I've reconstructed the ventral bodies, this piece of humerus, and I've used a cheap rod and screw construct. It doesn't look biomechanically as strong, but don't forget the thoracic spine, you have all these ribs in the cage holding together, so this works fine. It's an anterior only rod screw construct with a piece of humerus, obviously allografts. As a patient with osteosarc, with tumors, we tend to use cages. Now, obviously, you've got a big vertebra taken out here, so you want to use a cage which can expand. This is a easy end plate. You can turn inside and it clicks and opens, so you've got a range of cages. You can do entire vertebral body replacement. You fill this cage with bone graft, and I'll just put some rods and screws to try and stabilize it. That's a typical reconstruction cage, where it's expandable. You get these cages made of peat now and all sorts of different materials. A little bit about posterior thoracolumbar fixation, instrumentation. pedicle screws, once again, really powerful systems. This first third is the pedicle, so the modern screws got a differential pitch. The pitch here is a much tighter pitch than the coarse pitch which goes into the vertebral body, which is coarser. This is a fixed head screw, which is great for trauma, but you also may want polyaxial screws because it allows you to basically fit the screw onto the screw's got a fixed head, but it's got a monoplane movement. This is a polyaxial screw, we can move in different angles. There you can see the beautiful differential pitch. This part goes in the pedicle, this part goes in the vertebral body, which is cancellous, and it's much higher, much better biological fixation. So here's the pedicle anatomy, base of the facet joint and the transit process. That's where your pedicle starts, and your different angles, and your battery in the middle of the pedicle. So basically, the middle of the transit process is where your pedicle is going to be. There's different systems for trauma. This is a so-called Schon's pin. So you're putting it into the pedicle, it's the body. So I'll show you this patient's got looks like an unstable burst fracture. It's torn to the disc, he's got vertebrocesis there. The flavor looks intact here, but I guess I made the decision to fix him, not sure why. See it's lying on the table, see the kyphosis there. This is obviously different patients. So there's the spinal processes, there's a defect in the ligament, it's torn. This is the typical patient, you feel a gap in the back with the thumb and local tenderness. He's unstable, so it's anterior and posterior column injury. There's these beautiful Schon's pins, and they go onto they've got a polyaxial connecting device which goes into the rod and allows you to move them in different planes. So with this long tool, we can move them, we put them in like that because the fracture's in kyphosis, and you can then cross them over in lordosis and fix the head there. So your screws remain in the position on the rod. It's a great trauma system, very old, it looks very well. And obviously converging both sides, so you're getting a really good pull-out strength. So you have the screws inserted in the patient, and they're probably slightly convergent. And here you can see I'm closing down, so I'm diverging the screws in front and restoring the lordosis at this level. It's just a intraoperative picture, and then you lock these screws onto the rods, so you fix an angle. You can also distract them, so you can put a distractor and distract these screws to restore your vertebral body height. And there's your patient post-op. So the screws work. The fracture is probably convergent when I put them in, and after distracting them, I've restored the body height to a large extent with the system. So you can see there that's been fixed, and you've got a big tool which now you've got a big bolt cutter which cuts these all flush, so you don't have this obviously things sticking out. It's a typical posterior trauma pedicle screw system. Lumbar degenerative disease. So most of our surgery for lumbar degenerative is decompressions, and we may combine it with a fusion. The fusion rates are much higher than internal fixation. So there's different indications for fusion, so low back pain, instability, deformity, and stenosis. So here's instability in the patient with a rhesus. It's a 4-5 rhesus. The reason for that is mostly degenerative. You can see in the MRI these large facet joint fusions. And if it's more than 3 millimeters, it means it's probably unstable. If I deflect extrusion in this patient, you might find that it reduces on extension and moves in flexion. You see this canal's been markedly reduced in size. This canal should be shaped like that. You've got facet hypertrophy here, the ligaments and flavum is bunched up. This patient's got a miserable little trefoil-shaped canal. So this is just asking to be decompressed. As a patient with foraminal stenosis, you can see there is a spondylotary between whatever this is 4 and 5. There's a normal foramen, there's a nerve root there in the foramen. Yeah, the foramen, the nerves, the disc is rolled up in the foramen. You can see on the X-ray as well. It should be foramen there and there. Yeah, the foramen, the little tight space there. There's a patient with deformity. They've got a coronal deformity. Our fall looks like he's falling off to the side. The nerve is coming out here to go over the disc there on both sides, and you can only correct this with instrumentation. So it's another reason to instrument. These are posterior pedicle screws. Looks like there's a cage there. So our options with fusions on upper spine are posterior instrumentation, and the posterior instrumentation is usually pedicle screws, and you may choose to do anterior cages. Okay. So there's a patient with posterior only instrumentation. It's a spondylo, it's still a bit of diseases. I haven't restored the disc out here. The framing looks narrow, but I'll probably undercut away the facet joints, so I'll decompress this directly. But I have got the lordosis here, and with this vertebra should be probably angled like that. So it's remaining kyphosis, and this is how I used to fix it. This is a very old X-ray one of mine, and you can also appreciate. So where's my fusion? This will all become loose, and this bone grows with that bone. I can't get interbody fusion because I've done nothing here. I'm basically getting post-lateral fusion on the laminar and the transit processes for this patient. So mechanically, you can see the post-lateral fusion is not very good mechanically. With this long lever arm and moving to the front. So it's not a great technique. So I may want to get bone in between the bodies, so so-called interbody fusion. How do I get to the body? Well, I can go from behind. So from behind, it's called the so-called T-lift, translumbar interbody fusion, or transforaminal interbody fusion. So from behind, I come down in the axilla leverage, and I can take this entire disc out with tools, and then I stick a cage in. The cage has to be shaped like a banana because it's coming in the axilla. And you put it in the rotator, so it sits around here. And that cage is actually a spacer. You pack bone inside here, and you get interbody fusion. So that's the so-called T-lift. So the T-lift stands for transforaminal lumbar interbody fusion. Okay, going from behind and getting anterior interbody fusion from a posterior approach. So you can see the difference in this case. I'm jacked up the height. I've got better height. I've got better lordosis in the patient, and the screws are supported with the interbody cage. You can see they're much more rigid system than this, where the screws are basically not supported at all. I've got a big surface area for bone graft here, so my fusion rate is much higher. If you've got a smoker, you really want to try and get the best fusion you can, so you almost always have to do interbody fusion with smoker. So you scratch the entire disc out with a big footprint here for fusion. So there are some systems you can go percutaneously. This one's called a sextant, where you can basically put the screws through stab holes, and you rotate this curved rod in that delivers a rod into your screw heads, and you can see special rods at the point, and you end up with a percutaneous system. You can even do the cage percutaneously through smaller holes. These guys are like a sort of thing, and you basically end up with a whole lot of puncture holes in the skin, lots of damage inside, almost the same as if you did open surgery. Your fusion rate aren't as good. Screws tend to be, often placed. You don't appreciate the facet joints near, but the screws often violate the facet joints. I don't like doing it. I prefer safe open surgery. Okay, you may want to do interbody fusion from the front. So on this instance, I've got to the disc space by coming from behind. I may choose to come from the front, and so there's reasons why I may want to come from the front. So the approach in front is called the anterior lumbar interbody fusion. It's a retroperitoneal technique. So basically, you come around the retroperitoneum, and you come out here on your iliacus here, and so as you pull your order structures across. You don't see any intestines. You're going behind everything. Your ureter also goes with the peritoneum. You don't see the ureter in the way. And all your electrodes, the psoas muscle, and I think a genitofemoral nerve and some stuff there. It's a nice retroperitoneal approach. So if you're going to come from the front, you're not limited by trying to get a small cage to the axilla of a nerve ridge. you can put a great big chunk of cage in from the front, because in the front you get a beautiful exposure. There's nothing in the way. You can put in whatever size you want. So the advantage of going from the front is you can get a much bigger cage in. You look how much, I've almost got this thing parallel here. You've got a big footprint. This is actually a piece of femur. I think this patient might have had sepsis, but you can put a cage in. There's a cage there. It's a peak cage. Some of the cages got screws like this one, so it's designed to get a fusion here by going from the front only. Because of the screws, you don't need to put pedicle screws from behind. It's a standalone anterior cage, and it's called an ALIF, anterior lumbar interbody fusion. And yeah, so that's it. So the advantages of the ALIF technique, anterior fusions, you can directly restore your disc height. You can see the entire disc. So obviously you can see the whole thing. You can scrape the entire disc out and clear it. And you preserve your posterior muscles and tension band. So a lot of advantages to do the ALIF technique, especially standalone. You have a really big footprint for fusion, so the fusion rates are very high. There's almost no blood loss, theoretically. And because you haven't damaged the back muscles, patients are out of bed very quickly. So it's a very attractive sounding approach. You can go transperitoneal to the ALIF, but obviously, you know, you have to just pack intestines out the way. Patient might have a bit of ILS. The retroperitoneal avoids all that nonsense. But sometimes if you have previous surgery, the retroperitoneal might be scarred. You may have to go transperitoneal. There's some fusion devices on your anterior approach. So it depends where you're trying to get to. So L5 and S1 sits in the crotch of the bifurcation. You don't have to mobilize the vessels too much. If you're trying to get the 4 or 5 disc, usually the crotch sits about here, so you've got to move the vessels out the way. They also is not a problem to move, but the vein, especially the iliac vein, there's a little vein there called the ascending lumbar vein, which goes up here. And if you pull this vein across, you tear that vein, and your sucker goes very quiet, and the baby forms with blood. You lose a lot of blood very quickly, and it's a real bone fight. So your vascular anatomy is very important. These approaches, I won't bore you too much on that, but just note you've got nice exposure of the disc, but you have the vascular anatomy away. So theoretically, you can have a nice little small tongue incision and intraumbilical incision, and the patient's got like a cage or something in the front. A lot of complications, so ILS, retrograde ejaculation, vascular complications, urogenic, and so on and so on. The DLIF is called a direct lateral interbody fusion. So that comes from the side. Once again, because you don't have to weave the cage past the nerves, you can put a big footprint cage in the side and really get nice restoration of disc height. Big surface area, so your fusion rates are higher. Also, because you've got such a big surface area, it's less likely to subside into the bone and lose height. The DLIF's got a couple of advantages. So you can put in percutaneously. You can put in a little wire and just check with electrical current whether you get into the plexus or not. If you're happy, you can dilate it up, and you can basically do percutaneous DLIF, directly lateral, avoiding the stomach contents and peritoneum. You can directly lateral, and you can do discectomy. Problem with these little minimal access operations, you got a small little tube here, is that you basically seeing this, you're taking this out the disc, not clearing the whole disc out. So if you get infection or tumor, I'd like to see the disc more clearly. I do lots of DLIFs, but I like an open approach. It's almost like a appendicectomy. We do muscle splitting approach. I want to safely see my nerves, get them out the way, and do my DLIF. So that's a schematic of a DLIF from the side, direct lateral interbody fusion. The cage sits like that. You can see here there's percutaneous options and so on. You've got to monitor the plexus by that, but there's a high incidence of neuropraxia and so on. A little about lumbar arthroplasty. So obviously, if you can put a cage in here, fusion cage, you can put a disc replacement in. Arthroplasty has been gained since the 1950s. The first guys were lucky enough to get a metal ball bearing, which obviously didn't work very well. At the same time, Charney started with his hip stuff. So there's been many different devices, inelastic steel devices, elastic, silastic stuff. And they basically copied what is happening in the arthroplasty and tried to stick it in the spine. And had a whole bunch of stuff going on. There's hundreds of different implants in the markets. Some look almost like a real disc with this sort of like capsule to keep the wear particles inside. There's many different devices. Big problems that there's very steep learning curves. You're putting these devices into fairly young patients, whereas your arthroplasty, you tend to putting in patients much older. So these guys are often active. They want to run, play sports, do stuff, and you know these devices have to go through a lot more wear and tear than the average knee or hip replacement would. Most of them do have complications in 2 years, pretty soon, and the complications are huge. I mean, these patients have enormous vascular problems. You can tear the veins and so on. So there's big problems with them, and they don't show a significant advantage over well-chosen fusion. Let's end the slide today. See. There's more to my subject. Okay. So the motion preserving devices or your disc replacements from the front. There's also posterior motion preserving devices. So look, this is largely become historical now, but just to know about them, there's your pedicle fixation devices and the interspinous devices. So interspinous devices, XOP we spoke about it earlier on, these devices go between the spinous ligaments. You distract them and you're supposed to unbuckle the flavum of the spinal canal. This particular one, X-Top, was sold by companies in Francis Medical to Medtronic for a few billion. It's supposed to be the next best thing in the old backs, and I don't think I know if anybody puts them in anymore. So this is, you can see a myelogram. There's a patient sort of, or the X-Top, it's supposed to be a terrible picture, but you're basically supposed to be bucking the flavum out the patient's back. This one's called a DM. It looks like quite an interesting one. It's about I put a lot of these in, probably about 10. And it's basically a silicon little wing-shaped thing in this dacron mesh, which is suture. So there's a patient. I've done a discectomy. There's a little hemilaminotomy, and I'm basically between the spinous processes. I just put this little silicon thing spacer in, stick it in. There's a wing on each side, and you suture this tab so it doesn't displace. And it's supposed to distract the spinous processes, and you feel very good about yourself. But they don't work. Almost every single one, the spinous process erodes away, and you lose height. And I thought it might prevent recurrent disc. I was hoping it would prevent patients needing fusions. And of all the 10 I put in, I've taken every single one out, and not a single one of them prevented the patient developing the consequences of disc degenerative disease. So I don't do them anymore. There's a device called a Dionysus, and I'll put about 3 or 4 in, I think. Basically putting a pedicle screw in, and instead of a rigid rod, you've got this looks like a piece of hose pipe with a strong cord. And what it is, it's a very stiff mobile system. Okay, so it restricts motion between these two devices. So here's a patient who's got disc degeneration. There's a disc prolapse here. There's 2 levels bad discs here. And you don't want to do fusion in young patients. So remember, this disc is only degenerating because of gravity. You know, it's a mechanical thing. So this patient was weightless, or if you can unload that, you expect this degeneration to slow down. So as a patient is a rhodinosis, so these screws are put in, and don't forget you've got a flexible rod system in the back. So you can distract or unload these discs, and that's what it's trying to achieve. Because you're not getting solid fusion, you want to also make sure the screws don't loosen. So you can see the screws are HA coated to try and get bony on growth. Otherwise, they will loosen. You know, the ones I've put in, I think only one lasted for maybe give it 8 to 10 years of improvement. It's hard to know whether that's because of my decompression or because of the dionysus alone. I don't do them, but to just know that they are there. What's the role of instrumentation in infections? So you may reconstruct. Remember, the TB can have quite marked virtual body destruction. So you may want to reconstruct your anterior column. You may want to do only posterior stabilization, or you may want to combine the two. There's a patient with what looks like tuberculosis again, or some sort of infection, maybe it's a pyogenic infection, and I've done a total 2-body corpectomy, and I've just stabilized with a rod screw construct. As another patient who's got only a posterior construct, and you expand the virtual body in front. The VCR stands for vertebral column resection. So this patient's looks like tuberculosis and a large 2-body involvement destruction. There's some pus and abscess in the cord, and with the VCR, you just cut this whole bunch out and you reconstruct the column. So you put in screws below and above it. You then correct the deformity, and you remove this whole infected mass, and you put in that looks like a piece of humerus from behind. So that's what instrumentation allows you to do with infection. You can actually resect the infected column and reconstruct it with, in this instance, we're using a bone allograft, but people can use cages as well, just much more expensive. The tumors obviously want to be more aggressive to remove the margins. As a patient with osteosarc, again, you can see in the x-rays the sclerotic focus. I don't know, there's something there. There we go, big osteosarcoma, and you want to basically just get good margins. And I went from anterior, so the pathology is anterior, and he's got an expandable cage at the rod screw construct. So in summary, indications of fixed fractures are pretty much the same as general trauma. For degenerative disease, infections of tumors, if you have instability, or if you're going to cause instability with surgery by aggressive decompression, or if you need to remove some of the column, you want to reconstruct with instrumentation. If you want to achieve foraminal decompression, or if you want to correct deformity, or if you want to do anterior column reconstruction, that's indications of instrumentation. Tom Hilton there. Okay, does anybody have any questions?